morning, Cyberone. Dr. Kaushik from Mumbai. Today's talk show is regarding art and science of implant dentistry. We are blessed to have Dr. Udatta Kher sir on the show. Social, entrepreneurial, innovative, and one of the topmost implantologists of Mumbai, Dr. Udatta Kher sir. He has been graduated from GDC Mumbai in 1991 and post-graduation in oral surgery in 1995. He is a director of implant education and academy for dentists for the betterment of implant education and full mouth rehabilitation. He is expert with dental XP. He has authored the first ever textbook on partial extraction therapy published by Springer Publications. He is consultant oral surgeon and implantologist to the Governor of Maharashtra. He has unique distinction of lecturing in all the continents across the globe. Please welcome Dr. Udatta Kher sir on the show.
Thank you, Kaushik.
In this digital era, sir, will you please explain me your opinion about the awareness, knowledge and expectance of the patients towards the dental implants?
Yeah, Kaushik. So, I think in the last decade or so, we have seen an exponential growth in the field of dental implants. So, especially in the urban areas of, in India, I don't think there is any need to really convince patients about dental implants anymore. The awareness has increased so much over the years thanks to social media. Not just that, I think over the years, the number of people who have successfully got implants done itself, helps other patients take a decision on going in for dental implants. So, when I started my practice 30 years ago, it was all about root canals back then. So back then we had to talk patients out of doing extractions and opt for root canal treatments. But these days, it's a non-issue. Everybody you don't even have to tell patients about root canals. We've seen the same kind of change now in the patients' acceptance levels for implants. So nobody these days wants removable dentures, and patients have also understood the ill effects of bridges. So thanks to that, patients on their own are quite aware about the benefits of dental implants. So these days, it really does not take us too much of an effort to try and talk patients out of bridges and to go in for dental implants.
Okay. What makes you stand out to be one of the topmost implantologists across the globe?
Yeah, Kaushik. So it's hard to answer that question easily. I think it's just been, over the years, the discipline and practice. I think for somebody to be a successful implantologist, it's not just about being good at surgery. So as you're well aware, implantology is not just a surgical field, but also a very, very robust a restorative field. In fact, surgery forms only a small part of the entire gamut of implant dentistry. So my background being that though I have graduated, in oral surgery, I have actually taken great interest in routine general dentistry procedures. So right from the time I started practice, I've been, dabbling into not just surgical work, but also restorative work, composite work, root canals, and of course, a lot of prosthetic work, be it removable dentures or fixed partial dentures. So when you bring in all these virtues together, that's when implant dentistry comes quite easily to you. And I think that pretty much has been, the main reason why I feel I'm able to manage a lot of, variety of implant dentistry cases quite successfully. The other aspect also, I think somewhere in my nature is to basically simplify everything. I like to simplify my own life. So that I bring that into practice also, and I bring that into teaching also. So a lot of my patients accept my treatment plans because I've kind of simplified the treatment plans for them. So they find it quite easy to accept. And I think even when I'm teaching, it just comes very naturally for me to, try and simplify complex procedures and try and make it simple so that anybody who is learning can, pick that up fast and, basically shorten their learning curve. So I think that's what it is.
Will you please explain me the critical aspect of immediate loading implants, and what is the major difference between immediate loading implants versus immediate loading restorations?
Okay, so coming to immediate loading of implants, it essentially means that when implants have been placed, you connect a restoration onto it within the first 72 hours. So by definition, immediate loading is something where that restoration is going to be in functional, is going to have functional load, which means it is going to have occlusal contact with the opposing dentition.
Okay.
As against that, immediate restoration is something where similarly after the implants are placed, the implants receive a provisional restoration within 72 hours. But that restoration does not have occlusal contacts.
Okay.
So if you were to break it down, typically immediate loading is done for full arch cases, be it the maxilla or the mandible, wherein, once you put the prosthesis on immediately placed implants, you will always have functional load. Okay, I mean, you can't keep a full arch restoration out of occlusion.
The masticatory forces
will be there literally from day one. Compared to that, the immediate restoration is typically done in the aesthetic zone. So wherein maybe you're restoring one or two teeth, which are missing, and you place the implants and you attach a provisional restoration within 72 hours over those implants. But those restorations are always kept out of occlusion so as to avoid any kind of load onto that. So by definition, that qualifies to be an immediate restoration and not immediate loading.
What is your call for having the immediate loading restoration? What the material should be used in the restorative workflow?
Yeah, so for immediate loading, typically you want to use an acrylic based material. So previously we would use a lot of heat cured acrylic materials, which were actually in form of dentures, and then those dentures would get converted into a screw retained fixed provisional. But these days with so much of digital technology and CAD CAM, we are able to fabricate these prostheses in milled PMMA, which is polymethyl methacrylate. So ideally the materials have to be softer, they have to be much more lighter in weight and much friendly to the opposing dentition. And once the implants osseointegrate, then you basically move on from an acrylic material to then a material of your choice, which could be porcelain fused to metal, or could be zirconia, or could again be some kind of an acrylic material.
What would be your suggestion if, like, after the osseointegration has been done, what is your suggestion of having the indirect restorative workflow in zirconia or PFM or full met?
So actually the choice of material depends on several factors. And one of the main factors in this is the amount of restorative space that we have. Okay, so basically it means that what is going to be the overall height of the restoration. So if the restoration is going to be within limits in terms of height, then a strong material like zirconia or a porcelain fused to metal is ideally suited. But if the resorption is increased, then we use a much lighter material like acrylic or composite resin based. Or these days, a lot of the prostheses are also made in PEEK or bio-HPP materials, which are much lighter.
Yes.
So if the prosthesis is tending to become, quite large in size, then we have to use lighter materials such as PEEK and bio-HPP.
Opening of the incision line is most common post-operative complications. What would be the dentist can do to handle these post-operative complications?
So honestly, Kaushik, the opening of the incision line is not a very common occurrence. Perhaps it occurs more amongst novice clinicians, who are perhaps not trained very well in the field of basic surgical dentistry. So, I mean, these days I've seen a lot of dentists who are from non-surgical backgrounds, even those who are like endodontists and orthodontists who have now ventured into the field of implant dentistry, who typically come from a non-surgical background.
So, a number of people are doing the immediate loading implants right in front, like after 2-3 cases of placing in implants. What would be, I guess this might be the one of the reason?
No. So I think more of it comes from the fact that many dentists I've seen that have not really done enough of surgical work before they start doing implant dentistry. So because of that, they are not very comfortable with the process of incisions, reflections, and then, good watertight suturing. So when you don't suture well, it's likely to open up. And the way to get better at it is essentially do a lot of your basic surgical work before you start doing implant dentistry. So because I teach this on a regular basis, I also see a lot of clinicians who sometimes have never ever made an incision and never done a suturing. And the first time they're ever doing it is when they're going to do their first implant case. And I think that should not be the way it is to be handled. One should be fairly comfortable with the basics of incision, reflection, and suturing on cases which do not require any implants. And once you're like comfortable with that, then you venture into implant dentistry. And once you follow that path, you will not have this complication of the incision line opening that frequently.
So will you please explain me the comprehensive philosophy for edentulous arches?
Okay, so we actually have a publication on this called the ABCD classification. So this actually helps clinicians to formulate a treatment plan based on 4 factors for fully edentulous cases. So the 4 factors, quite simplified. The A stands for the age of the patient. So age is a very important criteria in decision making on firstly, how many implants we are going to place for a patient, and whether the patient is suited for a fixed prosthesis or a overdenture prosthesis. So depending on the age of the patient and the functional requirements, the number of implants and the spread of implants across the arch can be planned. So for instance, now these days we don't have necessarily have patients who are geriatric, who are in their 80s, who require full arch fixed prosthesis. At times we have patients who are in their 30s and 40s who have lost their complete dentition. It could be because of aggressive periodontitis, it could be because of some congenital defects. So at times we have to now plan full arch implant prosthesis for patients who are at that age. So if you can understand the difference between treating a 80-year-old and treating a 40-year-old, there firstly the longevity and the functional requirements are vastly different. So that will dictate the number and the spread of implants. Coming to the B, which stands for bone zones. So depending upon where the bone exists, the residual bone exists in the mouth, the decision on where to place the implants and how to place the implants plays a important role. So for instance, if somebody has good bone across the arch, from molar to molar, it makes sense to just place 6 straight implants across the arch and give the patient a full prosthesis. But sometimes there is no bone in the posteriors because of the sinus or maybe because of the posterior bone loss in the mandible. In those cases, then the tilted implant concept is pretty useful to give the patient a full arch fixed prosthesis. Now, and sometimes patients don't have bone, all the way till the canines. So, which means there's no bone in the molars, no bone in the premolars, and the bone exists only in the anteriors. Now, these are patients who are now typical candidates either for, sinus lift procedures and grafting procedures, or then the zygomatic implants. So that becomes your B, which stands for bone zones. Then the C stands for cosmetic display. So we know that when the patient smiles, some part of the teeth are going to be visible. And some patients have a very high lip line. So which means when they smile, you can actually see their alveolar ridge. And there are some patients who, when they smile, they can barely even show their teeth. So depending on how much cosmetic display is there, the type and design of prosthesis is to be planned. So that's the C, which is the cosmetic display. And the last of the series, which is D, which stands for degree of resorption, which again, like I just mentioned some time ago, depending on how much of resorption has taken place, the type of prosthesis and the material used for the prosthesis is to be decided. So like I said, for minimal amount of resorption, you will use like a porcelain fused to metal or a zirconia type of prosthesis. And for moderate amount of resorption, you will use lighter materials like acrylic with PEEK or bio-HPP framework. And whenever there is massive amount of resorption, where there is a lot of atrophy, in those cases, sometimes fixed restoration is not advised. And it's better to give the patient, overdentures, which is like a removable prosthesis. So this is in a nutshell the entire philosophy of, planning for fully edentulous patients, which can be quite simplified by following this guideline of the ABCD classification.
So, will you share me the article that where the article of ABCD classification as we mentioned?
Yes, so there is an article in the Journal of Implant Dentistry. So yeah, maybe I'll be able to share the link to that
the
that
viewers.
article. Yeah, I will be able to do that.
Will you explain me the common mistakes made by the dentist while placing the implants in the aesthetic zone?
Okay, so I think some of the biggest errors occur in the aesthetic zone. Two of the most common problems that will occur in the aesthetic zone are, one is faulty placement of the implant in terms of faulty angulation and faulty positioning. And the second is managing the soft and hard tissue around the implants in the aesthetic zone.
Okay.
So these are the two problems that will lead to not a failure of osseointegration, but definitely an aesthetic failure. So patients who need implants in the aesthetic zone, their expectations are pretty high when it comes to aesthetics. And if you place the implant in a wrong position, or you do not manage the soft tissue around the implants well, you're going to land up with a very poor aesthetic result. And the main causes for this is, if you were to classify that, one could be the errors in the planning, and second thing is errors in the execution. So when I'm talking about errors in the planning, I have seen that a lot of clinicians are very tempted to do extraction immediate placement in the aesthetic zone in cases which are actually not indicated for immediate placements. So for instance, there are cases where there is no labial bone present at all at the time of extraction. If you try to place implants into those areas, it takes a lot of effort to be able to manage a good aesthetic outcome in such cases. So I've seen, very poor results with extraction immediate placement cases where the buccal bone has not been managed well. That is one primary cause. And second is during execution. You see, the procedure requires a lot of experience, a lot of skill, and a lot of understanding of not just the surgery, but also the restorative aspects, and of course, cosmetics. So only when the clinician has a thorough understanding of all these principles can the clinician go ahead and place the implants in the right three-dimensional position so that you can give the patient a very nice aesthetic looking restorations. So, in a nutshell, managing cases in the aesthetic zone would require, thorough understanding of all the principles of aesthetics and to be able to place an implant in an ideal 3D position.
So, you are a director of implant education, and you are an expert on dental XP. What are the activities of implant education, and when it did formed?
Yeah, so Impart Education is a private academy that my friend Dr. Ali Tunkiwala and I started sometime in 2011. And the whole intention was to start sharing our own clinical experiences and try and train dentists in the field of implant dentistry and all allied procedures and into full mouth rehabilitations. So we started off with a very basic foundation level course in implant dentistry back in 2011. And over a period of time, we now have various courses in advanced surgical procedures, in advanced prosthetics for implants, full mouth rehabilitations, also for osseodensification, for immediate loading. So there is a plethora of different courses that we conduct over the year, throughout the year, under the aegis of Impart Education.
Okay. What is your take on All-on-4 and All-on-6 implant procedures?
Yeah, so I think, it's a time-tested procedure which is very, very well established now. So, for nearly over 15 years, clinicians have been doing it very successfully. So, wherever it is indicated, I think it's a great procedure. Specifically, when you're looking at a typical, 4 implants with 2 tilted implants and 2 straight implants, is a great option for the elderly population, patients who are almost in the geriatric age group, to minimize the surgical work for them and to be able to give them a good fixed restoration. Unfortunately, I also see that at times these kind of all-on-4 restorations are done on patients who are much younger. Like I said earlier, there are sometimes patients who are in their 30s and 40s or even early 50s who have lost all their teeth. So according to me, to place only 4 implants and give them a full fixed prosthesis is perhaps under engineering the case. So I feel in those situations it's better off putting more number of implants across the arch and giving the patient a more long-term solution on more number of implants. But yeah, so wherever it's indicated, the typical all-on-4 or all-on-6 is a great treatment option for fully edentulous patients.
Okay. There is a huge paradigm shift from the conventional to partial extraction therapy. What is your opinion regarding it? And you have been authored the first ever textbook on partial extraction therapy.
Yes, so yeah, I think partial extraction therapy is a game changer when it comes to maintaining soft and hard tissue in the aesthetic zone. From the time when we would do total extraction of a tooth and then place an implant and graft that site, in spite of that, we would not have consistent results. But with the advent of partial extraction therapy, specifically the socket shield procedure, we've been able to maintain the architecture of the soft tissue around implants in such a natural form that at times it's hard to even make out that there is an implant restoration somewhere in the mouth. So, I mean, as far as I'm concerned, it pretty much is a game changer, and it has changed the way I practice implant dentistry in the last decade or so.
It was such an amazing, insightful sharing of knowledge since past 20 minutes. Will you please tell me the innovative projects executed by you for the betterment of the community?
Yeah, so I mean, coming to something like MITSA, which is a minimally invasive procedure for doing crestal sinus lifts. Something that I published in I think 2014, 2015. So it was basically just a modification of the conventional osteotome technique, wherein I'm using a specific design, just a specific osteotome along with novobone putty to be able to manage fairly challenging cases of crestal sinus lifts. So whole point was to convert a lot of the direct sinus lift cases into the indirect sinus lift cases with this technique. So that modification worked really well, and we published that MITSA technique. And over the years, it has become extremely popular amongst clinicians. Going ahead, ever since the advent of the Versa burrs, the Densa burrs as we know them, somewhere in the year 2016 or 17 onwards, we have kind of moved away from using the osteotomes and using mainly the Densa burrs. And again, there are some very specific protocols that we follow using this to treat crestal sinus lifts. So in that field also, I'm actually trying to innovate a bit and try and come up with certain simpler protocols to be able to do sinus lifts more predictably and much faster. So that's something which is kind of in the pipeline, and hopefully you'll hear about it soon. Apart from that, the other thing that I feel very proud about is the fast tracking protocol that we had come up with in 2018. So this essentially was a treatment procedure where, after we typically do an immediate loading case for a full arch, where we've placed implants and now the implants have osseointegrated. So from there on, the conventional protocol would be to go through the entire prosthetic workflow, which would take around 6 to 7 appointments to go from provisional to the final restoration. But we came up with this innovative treatment solution, wherein we are able to convert from provisional and go directly to final in just one appointment. So that was a big boon, not only for the clinicians because of the number of appointments, but also high level of patient acceptance, because most of the times you see that the patients we treat are of the elderly age group, and for them to make so many appointments to the dentist is quite a difficult task. So if you are able to minimize those visits and go directly from provisional to final in literally one appointment, I think that itself is a game changer, and I think that's one innovation that I'm very, very proud of.
So let's play a rapid fire session.
Okay.
Here we will ask a series of questions and you just need to answer it across it.
Okay, I'll try my best.
So if not a dentist, what would you like to be in the future?
Okay, So I actually like the creative field a lot. So if it wasn't for dentistry, I would have loved to either be a cartoonist or a sculptor.
Because you are a sculptor, you are a clay sculptor, you are a photographer, you are like avid traveler.
Yeah. So I think I would have liked to be in one of the creative fields for sure.
Okay. If you get a chance to practice abroad or Mumbai, which city would you prefer and why?
I think I'll still prefer Mumbai. I think it's where I'm born, brought up.
Yeah.
All my education has happened here. I'm very proud to be a Mumbaikar, and I think the way we are seeing the whole India's success story and the growth story, I think all the action is happening in India, and Mumbai being the financial capital of India, I think there's no better place to be than to be in Mumbai. So I'm pretty happy with where I am.
Yeah. Sir, will you tell me what changes have occurred in the past 3 decades in general dentistry?
Yeah, so like I said earlier, I've been into general dentistry practice from 1991, from the time I graduated. So I've seen a fairly long transition in terms of what we were doing then and what we are doing now. So number one, of course, the overall awareness of dentistry has changed for the better amongst patients. So that itself is a big boon to the dentists of this generation compared to what it was 25, 30 years ago. Apart from that technology, I think back then, for us to get any new technology used to be a uphill task. It was not easy. It was not easily accessible. And I would say that there would be a good disconnect of at least 5 to 7 years between something that gets launched somewhere in the world and for a dentist in India to be able to use it routinely. Whereas I think that is now cut down to like no time at all. Anything that gets launched, any new technology gets launched anywhere in the world, also simultaneously gets launched in India. Plus the training around that is easily available for the dentist. So I think that is again a big change that has occurred over the last 2 to 3 decades in dentistry. In terms of patients, I think one thing that I must it's just an observation, but I do feel that the patients' pain thresholds have reduced over the years. I remember when we started off practice, we were doing a lot of procedures without local anesthesia. I mean, I'm talking of even simple restorations or crown preps. Back then we would do it. I'm talking of, no, I'm not even. I'm talking of the 90s when I was practicing actively in the 90s. We wouldn't give anesthesia for each and every procedure. For instance, if I was doing a crown prep or even a simple restoration, amalgam restoration back then, it was never done under local anesthesia. And I would feel, and back then our drills were also not all that great. But we felt patients would accept that treatment quite well. And when I see how we are practicing now, it's rare for me to do any single dental procedure without local anesthesia. So that itself, I think, has changed over the years, the way patients' pain thresholds have gone down.
Yes. We are blessed to have one of the renowned implantologists for sharing his knowledge. For the past 3 decades, he has been practicing implant dentistry and mentoring various students across the globe. Thank you, sir.
Thank you, Kaushik. Thank you for having me over on this show.